guest speaker, the Education and Cultural Partnership from Indonesian Embassy for the Netherlands, Azhari, Chairperson of Indonesian Student Association Utrecht. Ladies and gentlemen, good morning. We are gathered here today in this cool Saturday morning to hear a presentation about kidney disease. Our first event is an opening session. There will be an opening session from the chairperson of Indonesian Student Association Utrecht, Mr. Universitair, the Education and Cultural Attaché from Indonesian Embassy, Azhari, and National Anthem. To Mr. Universitair, the time is yours.
Good morning, ladies and gentlemen. I'm really honored to have a chance to address you in this precious moment. First of all, I would like to acknowledge the representative of Indonesian Embassy in The Hague, Professor, and also our outstanding speaker, Professor Frans Moll, and also Dr. Hidayat. Also, I would like to say thanks to our sponsor, the Airlangga Indonesia, the representative of Indonesia, Ms. Hidayat, and also the representative of Indonesian Prof Global Health Chapter, Dr. Tentang. Health is an important issue in our society. Therefore, it's simple knowledge with regard to health management and health insurance system. This event is about lecture talks to increase our understanding with regard to non-communicable disease as well as health management system in Indonesia. I would like to appreciate Indonesian Student Association in Utrecht and Indonesian Student Association in the Netherlands in general who organized this event. I hope this event will be beneficial to increase our understanding with regard to health issues in both international perspective and Indonesia. And to begin with, it's a tradition in Indonesian culture. If we want to start our event, we start with prayer. So let's silent for a while to pray. Yeah, thank you.
Thank you, the chairperson of the Indonesian Student Association. Next,
Assalamualaikum warahmatullahi wabarakatuh. A very good morning, ladies and gentlemen. More specifically to Professor Moll and Dr. Niko, who will be the speakers for today's Lingkar Inspirasi. It's been our pleasure to be here on behalf of the Embassy of the Republic of Indonesia in The Hague to join the discussion on the kidney treatments, both in the Netherlands and in Indonesia. I would like to apologize that since our beloved Ibu Retno Marsudi, our Lady Ambassador, left us a couple of months ago, we have already the Charge d'Affaires, Deputy Chief Missions, who is also unable to join this interesting discussion this morning due to his duty in Indonesia at this moment. With regard to all of the participants of Lingkar Inspirasi today in Utrecht. There is no doubt that the collaborations between the Netherlands and Indonesia in the field of health and medicine have been done since it was during the colonial period. We also know that the Ekman institutions has already been there since the beginning of 19th century, and we are also happy that we also have that institution at this moment also to facilitate our collaborations between Indonesia and Netherlands in the field of medicine and health. Not only between Indonesia and Netherlands, it's becoming also a global institutions. that will also support developing our knowledge and treatment methodologies in various diseases in Indonesia and also in the Netherlands. And today we will also hear presentations from both Professor Moll and Dr. Niko in regard to kidney treatments, which is also still a big challenge for us to face with the problem of health in Indonesia. And I certainly agree with Mas Yudhistira that health is a very important issue in order to develop our country through health and also development of human resource in Indonesia. So from the embassy, we are really supporting this activity, and hopefully that this discussion today will be producing fruitful results for the development of knowledge, and especially in the field of medicine, and to develop the health conditions in Indonesia and in the Netherlands by comparing and sharing both experiences and practices between the two countries. I wish you all the best. Good luck for the success of the discussions through the Lingkar Inspirasi in Utrecht today. Wassalamualaikum warahmatullahi wabarakatuh. Next will be the national anthem.
Indonesia airku, aku pada aku, di sana aku berdiri, jadi pandu ibuku. Indonesia kebangsaanku, bangsa dan tanah airku. Marilah kita berseru, Indonesia bersatu. Hiduplah tanahku, hiduplah negeriku, bangsaku, rakyatku semuanya. Bangunlah jiwanya, bangunlah badannya, untuk Indonesia Raya. Indonesia merdeka, merdeka, tanahku, negeriku yang ku cinta. Indonesia merdeka, merdeka, hiduplah Indonesia Raya. Indonesia merdeka, merdeka, tanahku, negeriku yang ku cinta. Indonesia merdeka, merdeka, hiduplah Indonesia Raya.
Thank you very much. So, to begin, how many from the audience that have really ever met or know a person with kidney disease? Anyone? Of course. No one? Have you probably ever really has to go in depth with their experience and learn something from them? Have you ever imagined, what if one of your family got a kidney disease, or even yourself, what would you do? Well, kidney is a very important organ. It functions to filtrate waste, toxic materials from blood to urine, and also maintain the blood pH in order to keep the body functioning properly. Well, in the case of chronic kidney disease, kidney functions deteriorates permanently and gradually throughout the years, and in the end stage of renal disease, where the kidney function is probably less than 15%, patients need to have a routine hemodialysis, that is cuci darah in our bahasa Indonesia. And or the definitive treatment will be a kidney transplantation. Well, I guess it is today we're here to discuss about the kidney disease in general perspective. You don't need to have a medical background to know that it is a really important issue. I have a data here that according to the World Health Organization, in 2012, in Indonesia, the WHO estimates around 50% of death is caused by chronic disease, heart disease, kidney disease, diabetes, surpassing the cause of death because of communicable disease and accidents, road traffic accidents, occupational accidents, and so many kind of accidents. And in 2011, the Indonesian Nephrology Society recorded around 12,000 patients every year need routine hemodialysis, and the number is increasing throughout the years. The number 12,000 patients per year is recorded from only 200 hemodialysis facilities in Indonesia. 200 hemodialysis facilities for our beloved Indonesia, for a country as big as Indonesia. Only 200 at that time. So from that statistics, we know that the problem is a tip of an iceberg. There's so many things that need to be done. To our distinguished guest, speaker, ladies and gentlemen, good morning. First, I will introduce myself. My name is Zayan Sundara. I'm a master student from Leiden University. I'm going to moderate this main session for the next 1.5 hours. To discuss more about this issue, we are very honored to have our distinguished speaker. First, our first speaker, Professor Frans Moll. I will read his biography, a short, no, not very short, I should tell, but very outstanding biography. Professor Moll graduated from medical school, University of Utrecht. He served the army for 1 year in the year 77 until 78. He started a surgical residency in 78 and completed his surgery training and PhD at University of Nijmegen in 1984. That's the year where I was. And then in 1991, he became the head of the vascular surgery training program and became a full professor of vascular surgery and the head of the Department of Vascular Surgery in University Medical Center Utrecht in 2003. Professor Moll also holds some patent of several inventions in vascular surgery devices, rings and several devices. He received the officer in the Order of Orange Nassau in 2009 from the Queen, I believe. Yes. And served as the president of European Society for Vascular Surgery from 2008 till 2009. He is has been appointed as research supervisor in Hidayat Institute from 2006. He is also the chief editor, chairman, member of board, director of so many professional international journals. Professor Moll. It is really an honor to have you here, sir. But and we have our second speaker that comes far away from Indonesia, Dr. Niko Azhari Hidayat, spesialis bedah thorax dan Vascular. He was born in Malang, graduated from medical school in Hidayat University dan Pasar Paling in 2004. He completed his CardioThoracic and vascular surgery training from Universitair Airlangga in 2013, and since now and then served as a national civil employee in the Airlangga University Hospital as the first staff to build the CardioThoracic and vascular surgery unit. He developed his interest in vascular surgery since the surgery training, and now he's here to receive a fellowship in vascular and endovascular surgery with Professor Moll in University Medical Center Utrecht. Well, I heard from Dr. Niko that the first time he met you, is when he drives you from the airport to every route in Surabaya during such a program in 2008. It's very nice to have you, Dr. Niko. Please come forward. So, without further ado, we are going to hear the first presentation from Professor Moll. Professor Moll, the time is yours.
First of all, I would like to thank you for this wonderful invitation, and a great pleasure to at least contribute a very little bit to the Indonesian community, which I truly, sincerely appreciate and esteem very high. Let me explain a little bit how Niko and I met so many years ago, well, so many years ago, 2008. But I'm active as a volunteer for the Foundation for Postmedical Postgraduate Medical Education in the University of Indonesia, Jakarta, and Airlangga in Surabaya. And each year we try to collect a number of professors from the different universities, not always Utrecht, but also Groningen, Leiden, Maastricht, Rotterdam, Amsterdam, to give and to contribute a course together with the professors of the two universities from Jakarta and Surabaya. And the dean of each university communicate with each other, and they make the decision about which subject. So, for example, in April, the foundation is sending 4 professors of urology and radiology, and also psychology. Yes, come in. To the Jakarta and Surabaya, and together with the professors from Indonesia, we give the course about stress incontinence and diagnosis of urology problems. In the autumn, we will dedicate the subject to allergy. So each time it will be a different subject, and we try to exchange knowledge and learn from the situation in Indonesia, and just like you mentioned in your introduction, compare a little bit between the two countries. And then, indeed, Niko was a resident at the last years of his training, and he drove me from the airport to the hospital, and from the hospital to another hospital, and it was a great time. And he applied for a scholarship, and I'm very happy that he managed to come over to Utrecht and to work with us for a full year. And we certainly will extend our friendship and collaboration over the next couple of years. So having said that, and again, it's a great pleasure to be here. The theme, as you all know, is kidney disease. And kidney disease will happen a lot in every country, in every place of the world. So it is a global problem, I apologize, and not only for Indonesia or for the Netherlands. And the theme is to discuss about this. It's not only that it disturbs your life, but it's also, very costly, because there's a big price involved with all this kind of discomfort. So, what is actually the main cause that your kidney does not function anymore, and that you either die, or that you should get hemodialysis, or, as you mentioned, transplantation? Well, I think diabetes is one important cause, and of course blood pressure. And very often these go hand in hand, but there are many other causes as well, and also congenital causes, of course. To give you a little impression about our very small country, the Netherlands, 17 million people, and Indonesia 250 million, maybe more. If some islands are forgotten, it might be 270 million maybe. But 1,213 per 100,000 per year in the adult population. It happens also in children, but I will address that later. The incidence rate increases by age and was the highest in the patients with diabetes. To 25,000 per 100,000 patients years, and so more than 75% of the patients with diabetes. If we go then to the US, the costs and effects of treating kidney failure are of course enormous. And here you can see that 1 out of 9 American adults has kidney disease. And of course the figures are a little bit late because it takes a couple of years when you collect all these numbers. But just 5 years ago, dialysis was estimated to be more than, well, you can hardly not pronounce that amount of money. And the treatment costs for hemodialysis patients per patient is 82,000 US dollars per patient. And for dialysis, peritoneal dialysis. The peritoneal dialysis is that you have a little tube in your belly and then you flush. Yeah, please come in. There are places here in the front and that row. Please don't keep standing up because it's a circle of inspiration and it's not necessary to be shy, because if you are shy, we cannot inspire each other. So please sit down, you are very welcome. And it was very cold, so I understand that some people have a little bit delayed because sometimes it's too cold here. It's good for the mice, and they die, and the agriculture, there are too many mice at the moment. But almost 30,000 euros for transplant patient. The government, yes, the government, always the government, plays a key role. They have to inventory how much is the disease present in your country. And you have to set up a program to protect for the major risk factors. And to protect the major patients from the major risk factors, you can improve prevention and treatment. So it might be an idea to set up national targets. It is worth to consider that, to warn the people of danger and promote health, diet, and lifestyle, and to regulate them. So improving kidney disease and healthy kidney in the whole world, I think we have the tools, the mission, and of course our long-term commitment, as is also as a statement, a letter of intent produced by the World Kidney Day and the International Federation of Kidney Foundations. And here you can always see you have the community, and here you have the health system and the health professionals, the nurses, the doctors, the physicians, and of course the local legislation, the regulation, and the policy, and all together you have here the international environment. And chronic dialysis versus kidney treatment is always a balance here between money, comfort, discomfort, quality of life, and how to have the best life if possible. The proportion of kidney treatment, and here you see per capita in US dollars, and of course you see here all the different countries, and Norway and USA over here, and here you see the countries who have are still trying to find better solutions to treat and to prevent kidney disease and how to treat it. That is here in this lower region. We have a Dutch Kidney Foundation, like many countries over the whole world. Our Dutch Kidney Foundation started immediately after World War II. And the mission statement is that you can stay alive with a good quality of life. And of course, everybody is encouraged to have more donors, and of course, better prevention and creation of a portable artificial kidney, so that you can go home with your hemodialysis and that you don't have to go to the hospital. And you have to be informed about the dialysis as one of the surviving methods. And improving the life of the kidney patient, it is necessary that you collaborate and cooperate with patients, researchers, health professionals, the people who supply the money for it, corporate sponsors, volunteers, and many others. In the Netherlands, as I mentioned, we have almost 17 million people and 4,500 patients in 50 well-distributed centers. Peritoneal dialysis is only about 29%. Hemodialysis, so you go to the hospital, most of them at least, some have these machines at home, but that is not very often. Only 2% receive hemodialysis at home of patients under 50. Only 50 are on dialysis, and more than 100 have functioning grafts to have access for the dialysis. So the better solution will be kidney transplantation. 500 transplantations per year, approximately in 7. One academic hospital in Holland is not doing kidney transplantation, but all the other hospitals are doing kidney transplantation. Most is from patients who died, so car accidents or other accidents, and about 100, but this number is increasing, from living donors. So family-related people who are willing to give one kidney to a person they really care about. We have about 1,200 patients on the waiting list, so they are still on dialysis and they wait to receive a kidney. And a total 700 grafts from living donors and over 3,800 from deceased patients, enable about 4,500 people with kidney disease to lead a more or less normal life, because transplantation is going better and better, and the drugs that you have to take to stop the rejection are still much better than several years ago. So how we do it? It's a team approach. The government controls the location where you can do the kidney transplantation. The government controls also the funding for it and the fee, etc. We have a kidney day. This is usually in the beginning of October. The Kidney Foundation invests in research, also in Utrecht, to improve the quality of the transplant and the preservation of the kidneys. And we call it international collaboration. Internationaal samenwerken is the key, because we have a Euro transplant. Holland is too small. Indonesia is big enough because you have 250 million. So there's a big group of people where you can get the donors from. There are a couple of seats here also in the front, so please go ahead. And this is from the Nephrology Dialysis Transplant Journal. Here you can see it, just in 2013. The Biobank of Nephrological Diseases in the Netherlands covered a string of quills, initiative, collaboration on chronic kidney disease in the university medical centers in the Netherlands. So one of the statements and the missions, but of course our esteemed chairman will elucidate more this morning, but one of the points is that you have to collaborate, because if you live on an island, a kidney transplantation program is very difficult to establish. So collaboration is a key mission statement. The program, nephrologists, we have the paramedics, of course, who are necessary in each organization. Then the transplant cord, then the kidney can be implanted, and usually with a good success. And we have this program now running for the last 30 years. Here you have a view in the OR, because we started to take out the kidney from a person who is willing to donate his kidney to a beloved partner, and we do that laparoscopically so that you do not have a lot of scars when you give the kidney to somebody you love. And it's a small incision, and the kidney is then taken out. Here you can see how it works in our hospital, and the kidney is then being flushed, cleaned, etc. In Leiden is a big center also for kidney transplantation. It's packed in the ice, and then the patient is called in and gets the kidney from his friend in his own body. So people's movements are essentially, the World Kidney Day is there, and please Google about it. March 2015 is very soon, March 12th, people's movements in the world, and the take-home messages at this moment from my side, but there will be more discussion this morning, is prevention is the best. Blood pressure control is always to be started with. You have to start with the beginning. And kidney healthcare should be comprehensive. Of course, we all have to do our best efforts to set up a kidney transplantation program. That is essential. And to accomplish this, to achieve this, people, government, medical staffs, and the politicians have to work together. Nothing is impossible. Thank you.
Thank you very much, Professor Moll, for a very clear and inspiring lecture. For the next speaker, we will hold the question session to the end of the presentation. So please hold your question and probably can make some notes first. Our next presentation is from Dr. Niko, who's going to present about the current status of healthcare in Indonesia in the BPJS era. So Dr. Niko, time is yours.
Before I begin, I would like to say thanks to all the colleagues and audience that will be here, and especially it is my honor and our honor for I never met before Mr. Roy and Kathy.
Yeah.
Nice to meet you this morning. And they are our special guests that will share to us their experience in kidney transplant.
Yeah.
And recipient. They are couples, and like you said, Professor, they are in love. They are sharing their organs and heart. Thank you for your time. Yeah. And before I present my presentation, I would like to show first one short movie about the Indonesian. So this patient is Azhari. She's actually living in the middle of Java, and she was a student actually from medical students in Surakarta, but then dropped out because this disease. Second semester and then dropped out. Went to Universitair in Surakarta, and she also liked to share her experience. And it's very lovely that she made her testimony to us, to this event, especially.
Umur 39 tahun. Saya didiagnosa dengan diabetes tanggal 7 Agustus tahun 1995 dan menjalani uji darah yang pertama pada tanggal 9 Agustus 1995. Ketika pertama kali tahu bahwa saya menderita gagal ginjal, itu saja saya sangat shock. Apalagi saat itu saya masih remaja dan merasa bahwa masa depan saya masih panjang. Tetapi semua impian saya hancur. Pertama kali memasuki ruangan cedera itu saja sangat menakutkan dan berharap itu adalah waktu pertama kali dan terakhir kalinya. Tapi ternyata itu harus saya lakukan berulang kali. Kemudian saya telah menjalani pemeriksaan dan berbagai macam tes darah, pemeriksaan X-ray, USG sampai ke rentgen yang menyatakan bahwa fungsi ginjal saya sudah sangat kecil, sehingga saya harus menjalani uji darah untuk hidup. Ketika sedang dalam perawatan, seorang dokter menceritakan bahwa gagal ginjal bisa kita lakukan terapi selain uji darah dengan transplantasi ginjal. Awalnya saya juga takut dan tidak berpikir bahwa saya bisa menjalani transplantasi ginjal itu. Tapi ibu yang sangat berkeinginan kuat, sangat mendorong itu, dan bahkan ibu yang awalnya berencana untuk mendonorkan ginjalnya untuk saya. Akhirnya transplantasi ginjal bisa dilakukan pada tanggal 7 Desember tahun 1996 di RSP Dr. CardioThoracic Jakarta dengan donor ayah kandung saya. Ayah tidak tega pada ibu yang harus mendonorkan ginjalnya, maka dari itu ayah dan ibu sama-sama diperiksa, dicari mana yang paling cocok. Dari hasil pemeriksaan HLA, dokter menjelaskan bahwa bapak dan ibu mempunyai tingkat kecocokan yang sama untuk saya, sehingga diputuskan bahwa bapak yang mendonorkan ginjalnya untuk saya. Itu selama 9 tahun saya bebas dari ginjal. Tapi selama 9 tahun itu hidup saya tidak mulus-mulus saja, banyak hal yang terjadi. Seperti kejadian setelah baru 2 minggu setelah operasi transportasi. Saya mendapati kaki kanan saya bengkak, dan kemudian setelah dilakukan observasi oleh dokter ternyata ada di bekas dada bekas operasi ada cairan yang mengenang, sehingga mengenangi ginjal coklat dan terjadi hidronephrosis. Setelah observasi lagi, kemudian dokter memutuskan harus dilakukan operasi ulang. Setelah operasi itu saya 1 bulan dirawat, kemudian diberikan pulang. Tapi tidak lama di rumah, ternyata memang kondisi saya belum juga membaik. Saya masih sering merasakan nyeri pada daerah operasi. Dan ternyata setelah dilakukan pemeriksaan darah, deposit saya sangat tinggi, sampai 25 itu. Kemudian dokter memutuskan saya untuk kembali menjalani rawat inap. Ternyata ada infeksi saraf. Kemudian dokter memberikan obat antibiotik yang pada waktu itu harganya sangat mahal bagi keluarga kami yang sudah kehabisan uang untuk biaya transplantasi. Pada akhir tahun 2001, kondisi saya semakin memburuk, saya keluar kerja. Bahkan dokter memasang diagnosa dan kemudian saya dimasukkan ke perawatan penyakit jiwa karena waktu itu sebenarnya dokter ada lembaga tapi dokter tidak tentangnya. Kemudian tahun 2005 ada masa yang paling buruk dalam hidup saya kembali terjadi. Diawali dengan serangan virus CMV pada awal tahun yang membuat fungsi ginjal rongga saya pertengahan tahun saya mengalami kejang yang saya sendiri tidak sampai sekarang tidak tahu apa penyebab pastinya. Jadi kejang itu membuat saya nyaris lepas karena cedera tulang belakang itu pada saat dan terjadi serangan infeksi CMV yang kedua. Dan cerita keluarga dokter mengatakan bahwa serangan infeksi CMV itu sampai ke otak sehingga saya mengalami sakit kepala yang sangat untuk beberapa waktu. Tapi waktu itu kondisi saya sudah HB sampai turun di angka 5 dan harus transfusi. Dan setelah transfusi justru saya melupa, saya tidak bisa keluar. Dan akhirnya dokter memutuskan saya harus menjalani perjalanan lagi. Tapi dokter tidak mengatakan bahwa saya akan harus kembali menjalani perjalanan untuk semua hidup. Dokter hanya akan berkata bahwa mungkin ini perjalanan hanya untuk 4 kali. Ya, saya pasrah. Operasi yang paling membekas yang paling membuat saya tidak lupa adalah pada tahun 2011, yaitu pembuatan sebenarnya di kepala, sehingga dokter memutuskan bahwa pembuatan operasi simino itu dilakukan di kepala karena operasi ginjal otomatis akan berarti pemeriksaan lebih. Akhirnya operasi dilakukan, tetapi ternyata gagal juga. Ketika saya baru tersadar dari obat, dokter menjelaskan bahwa operasi gagal dan bahkan terjadi komplikasi pada waktu operasi, yaitu ketika vena disambungkan ke arteri, kemudian dari arteri dialirkan ke vena, terjadi pembekuan darah. Akibatnya operasi dilanjutkan dengan pembalian darah itu kan pembalian sama itu banyak seperti total dan otomatis operasi simino gagal. Bahkan akibat dari operasi itu akibat dari pembekuan darah itu kaki saya yaitu kaki kiri yang dilakukan operasi menjadi ada gangguan. Tetapi menurut dokter gangguan itu tidak akan menimbulkan, tidak akan berbahaya karena saya masih bisa merasakan meskipun saat itu suhu lari saya gini, bahkan diperiksa dengan alat menunjukkan oksigenasinya sangat kurang. Operasi saat itu meskipun gagal tetapi membuat hidup saya sangat berubah. Di situ saya menyadari bahwa semua orang punya masalah, semua orang punya rasa sakit, dan yang bisa dimiliki hanyalah waktu ini, hanya sekarang, tidak masa lampau, tidak bisa masa depan, hanya sekarang, saat ini. Masa lampau sudah berlalu, apapun yang terjadi di masa lampau, sakit apapun masalah itu sudah berlalu. Karena masa depan adalah belum terjadi, dari masa ini adalah yang kita miliki. Jadi hanya inilah yang bisa kita lakukan, hanya inilah yang bisa kita nikmati. Harapan saya terhadap pemerintah, Kementerian Kesehatan dan Medisch adalah saya berharap bahwa semua pasien gagal ginjal yang memerlukan terapi hemodialisis maupun CABG mendapatkan fasilitas dari hemodialisis dan CABG itu dengan gratis termasuk semua obat-obatan yang diperlukan. Adanya standarisasi unit hemodialisis dari semua unit hemodialisis yang ada, selain adanya penambahan unit hemodialisis, peningkatan transplantasi ginjal di Indonesia. Memang banyak kendala transplantasi ginjal di Indonesia. Yang pertama adalah donor, karena di Indonesia hanya bisa dilakukan dengan living donor, yaitu dari donor hidup. Seandainya saja bisa dilakukan dari donor kadaver seperti di negara maju, pasti transplantasi ginjal akan lebih banyak. Indonesia ini dengan jumlah penduduk yang 250 juta, setahu saya untuk saat ini hanya ada 80 orang dokter kehamilan. Jadi harapan saya diperbanyak beasiswa untuk pendidikan dokter menjadi dokter spesialis ginjal, sehingga makin banyak dokter yang berminat untuk mengambil spesialis ginjal. Tuhan masih menganugerahkan hidup saya, berarti bahwa masih ada rencana Tuhan untuk saya, masih ada tugas-tugas yang diberikan Tuhan untuk saya. Saat ini yang saya lakukan adalah terutama fokus untuk memberikan motivasi, untuk memberikan sharing pengalaman hidup saya, pengalaman ginjal saya kepada teman-teman saya yang masih baru, mereka yang masih belum tahu apa-apa, mereka masih tidak tahu bertanya kepada siapa. Saya berusaha membantu mereka. Saat ini saya dan teman-teman bergabung dalam grup di Facebook, grup hidup ginjal muda yang sangat membantu saya dan teman-teman dalam menjalani kehidupan sebagai pasien gagal ginjal yang harus menjalani darah, CABG ataupun yang hidup dengan transplantasi ginjal. Itu kami berbagi dari hanya secara online dan kadang kami mengadakan pertemuan-pertemuan untuk seperti ya, misalnya untuk dari pertemuan inilah kami merasa semangat hidup benar-benar terhadirkan. Karena saya sudah mempunyai arti hidup yang lebih karena saya sudah memiliki pengalaman saya yang sudah 19 tahun lebih bekerja dan banyak juga yang sudah mengatakan kepada saya bahwa mengingat saya yang sudah sekian lama bekerja pasti bisa bertahan, mereka lebih semangat, mereka jadi lebih ingin hidup lagi. Bukan hanya sekedar hidup yang hanya susah, hanya kepaksa, tetapi hidup yang menyenangkan.
So, well, this is a very touchy movie, I think, and she tries to give to any of us to motivate us, everybody here, to encourage to know more about kidney disease, and also it's my honor to her, because she also gives full attention to the society and then the academy, to also the government, to get another more experts in Indonesia on kidney. So it's very nice. And next, my presentation will be speaking about current state of Indonesia healthcare in the Medisch era. I think this is quite essential to be discussed. It's like only sharing, and you can discuss it later. Yeah. First, Indonesia and healthcare. We know that Indonesia, the population in 2013 is 249, but actually now it's larger. Professor Moll said that 250 something, 52 or 53, maybe the
70 million.
billion. Yeah. And with the gross national income per capita, it's about $9,000 US. And this is the life expectancy for male and female, about 65, and the total health GDP expenditure is 3%. I will explore this a little bit further, and since I'm a medical officer, I should read these books since 2004, 7, 8. This is very nice book, but in fact I found some problems with it. That maybe after this event we can make something to give government recommends, or why it is a problem. You see, if we are a country that built a healthcare system, we should know what is the problem. Right? We should know what is the problem. If our colleagues here read these books, I don't think it describes very well. I don't think it is. It describes complete and full about what is the priority, what is the importance of the health disease or healthcare. I give one actual example is that the largest health disease, like Hidayat and now it is a non-communicable disease, which is cardiovascular and cancer, because these two diseases have the mortality, the highest mortality. But in this latest book in 2013, it only described in 2 pages actually. So I don't think it's enough. I don't think it's enough. And the trend is changing now. The trend, I mean, back years ago, we are discussing about infection. But now malaria, typhoid fever is not more being a problem for Indonesia. But now it's more to be non-communicable disease, it's degenerative disease, like also kidney disease. And what is WHO say about this? Is the data? Yes, there should be indicators, general and also the morbidity. And this is the resume. About 71% of total death is because of non-communicable disease. But you know what I found? I analyzed that in Indonesian data, it's only 58%. It's said by the Ministry of Health, the latest, Mrs. Moll. And we can see the difference. Why is it different? I mean, the WHO said 71%, but our ministry said 58%. But the difference of data, I think it's good to know, good to discuss, and we should comprised it very well. And this is the Indonesian population. In 2025, there will be reshaping of the ages population. We should ready for it. And of course, for elderly will be much, almost double. And we should prepare on this. Population is growing. Yeah. And become more and more and more. So, yeah, this is Indonesia. And also poverty. We can see in the picture that there's a fat doctor asking, do you have money? If you don't have money, you cannot be sick, you can be ill. It was years ago, yes. And yes, poor people is near to disease, of course. And this is one book. Orang miskin dilarang sakit. Poor people forbidden to get ill. And that's why BPJS come. And then, yes, but the fact is that they're still coming. They are still ill, you get sick, and of course we should ask if we see the pictures. How is the quality of the healthcare? If we saw any of these pictures, they came to seek help, but yeah. Okay, this is the BPJS. BPJS is Badan Penyelenggara Jaminan Sosial. It is a universal health coverage by the WHO. And it is just started in 2014 in January, so it's very fresh, very new. And yes, of course, there is a weakness, and also we have to encourage more the improvement. And this is the Director General of the WHO said that she regards the universal health coverage as the single most powerful concept that public health has to offer. It is inclusive, it unifies services, and delivers them in a comprehensive and integrated way based on primary health care. So, yes, primary health care. Prevention is the best. And this is the regulation, Undang-Undang, the rule, 2004, 2011. And this is obligation. This is obligatory to every citizen of Indonesia, and also for the foreigners that live in Indonesia at least 6 months. And with the principle, three principles is humanity, usefulness, and social welfare. And what is the content is accident, elderly, pension, and death. BPJS is now being the hot new trending topics. In many newspapers, we read every day about problems of BPJS and healthcare and everything. That yes, we growing and growing more. And of course, for the government, still complete that. Yeah, of course, this is good for the people, all of the people, especially for poor people, because before years ago, poor people cannot be ill now. Yeah, please ill, not I'm not saying like that, but yes, yeah, this is our president, Mr. Jokowi and Suarez, and with his cards. And all I can say that yes, card is very inspiring, and this is good idea, good thoughts, yeah. But of course, we should prefer more. What about it? What is the process? How is the process to make it better healthcare? And meanwhile, we learn about the budgets. Professor Moll said GDP also play the key role. What is or how big is the budget for health in Indonesia? This is the health expenditure, 1.5. But is this for real? Low health budget we have. But yeah, you see, this is the trend actually from 2005 until 2013. Yeah, it's getting bigger. But the regulation already said that it is 5% for health budget. It is the law, is the rule. But you see, our expenditure is quite still low, like 3 or 2%. So how can we develop a good healthcare system if the budget is not that enough? Well, this is actually the scale. This is the national budget, and this 5% health fund. And come back again. I bring the Undang-Undang Regulation Number 36, 2009, 5% for health care. And this is the APBN, budget for country budget for each department. For Ministry of Health, 47 trillion billion. Yeah. So compared with other departments, still quite low. And yeah, since we are in the Netherlands, allow me to just compare a little. But of course, okay. The total population 70 million is 200, but the total expenditure is 4 times. Okay, we just compare it with the neighbors, our neighbors, Malaysia and Singapore. Yeah, of course, Indonesia is dominant in population, of course. But yeah, gross national income is, yeah, we are still below. But the total expenditure is, we are still 3%, Malaysia 4%, and Singapore is 4.7%. Okay, we come to the kidney health care. You said that 70,000 kidney failure, and it is increasing, and there's a problem with high incidence, low preventive medicine, less comprehensive kidney treatment and management. This is that I take from the website. This is our former Ministry of Health. They said that they are going to enlarge the unit kidney transplant center in Indonesia. I think this website I took from the 2012 or 11, but I don't see it until now, I suppose. And where are we now? This is where I am. Kidney transplant since 1977, and until 2020, we are only done like 600 or 700 of yeah. It is like almost for 40 years, but 700 procedure of kidney transplant. But we are here in Utrecht in only one center, 120, and they're 150 a year. Not yet Groningen, Rotterdam, and all the other Netherlands. So, yeah, there should be also a problem. The other problem is that people who don't know about this, they are actively offering and for money. So this is very painful for any of us. I mean, they are very active into Facebook, then comment, or they will show their kidneys. So government and we as a people who know this should help, and we have to move together. Because it is local election. And the take message is that we have to inspire ourselves into action. Yeah. And after this meeting, of course, we have to build a network and spread these ideas and giving press releases and send the message to the government and also to shareholders, leaders in Indonesia, government, yeah, and also for the NGOs like the Indonesian diaspora with healthcare task force, I4, because usually government hear what scientists say, right? So we have to move together. And of course, preventive still remains best option. And I would like to give another more inspiring that especially for PPI Utrecht. This is the first human pelajar in Indonesia. Yeah. And I hope this picture will also motivate all of us that even though like we are students or we are young generation, many years ago they struggle with the bullets and then science, but now we are in a peaceful condition. We should fight a little bit more because we can. Thank you very much.
Thank you very much for Dr. Niko presentation, for the clear presentation, and the staggering facts that we have as a country. That now we know that Indonesia only spent like 3 to 5% from the gross the allocation to the healthcare expenditure. It's quite low as a country, and I know that it is even lower compared to some countries in Africa. Yes, it is part of our duty, not the whole blame to the government, because I think if you talk to people from the Ministry of Education, say that the education is very important. When you talk to doctors always say health is important. So it's a matter of perspective. It is how that we can sit together, discuss, and have the same perspective on the same issues. That would be a very good starting point to overcome an issue. I think, thank you very much for the presentation. Now we are going to have a discussion section, but before we are inviting the patients to please. For the next section. So we have a special guest today. This is Bapak Roy and Ibu Teti. The patient is not really fluent in English, but very fluent in Dutch. Maar ook spreekt een beetje Nederlands. So the next conversation will be in bahasa Indonesia. Terima kasih sudah datang. Bapak Roy, dulu gimana ceritanya? Dapat penyakit ginjal sejak kapan?
Dari dia
penyakit ginjal udah lama.
Ya,
Cuman
dialisis 4 tahun.
dari tahun 2009 sampai tahun 2012 4 tahun dia dialisis.
Di sini.
Di sini.
Di Rumah Sakit Antonius.
Sampai ditransplantasi tahun 2012
September.
Jadi sekarang masih makan obat.
Mungkin dia obat di
ya.
sini belum sampai.
12 macam.
12 macam. Dulu pertama kali tahu penyakit ginjal itu karena apa, Pak?
Karena dia minum obat litium.
Oh ya, karena litium.
Litium itu merusak ginjal. Untuk penyakit manusia depresif.
Ya.
Dia menulis stage.
Ya.
Terus dia bertahun-tahun minum itu ya.
Tapi sekarang gimana, Pak? Sudah terasa lebih baik waktu dibandingkan dulu waktu dialisis?
Iya.
Sudah baik.
Begitu dioperasi, kemudian harinya dia sudah bisa berjalan pakai kateter ke kamar saya, sedangkan saya lemah sekali badan saya. Terus ya, jadi kan saya kekurangan satu.
Iya.
Dia dapat tahu, jadinya saya yang lemah, dia yang sehat.
Ya.
Jadi sekarang sebagian dari ibu ada di bapak, benar-benar ya Bu ya?
Iya.
Dulu pengalamannya ibu gimana waktu coba donorkan ginjal, masih pakai metode yang biasa dibuka atau pakai laparoskopi yang
3 titik di perut dan 1 di bawah.
Iya.
Ya. Jadi sekarang ibu gimana setelah memberikan sebagian untuk bapak ginjalnya, 1 ginjalnya, sekarang ibu ada keluhan atau tidak? Baik-baik saja. Kontrol teratur.
Tadinya
Belum mau
Saya banyak sekali.
saya tiap
Jangan dibagi juga, Pak.
dulu 3 bulan sekali dikontrol, Setelah itu setahun sekali. Kalau dia masih kontrol terus setahun,
3 bulan.
dalam 1 tahun itu kontrolnya sering sekali.
3
Terus
bulan.
tahun kedua 3 bulan.
Okay. Baik.
Yeah, well, maybe one question that many people ask about is, what is the effect of the donor? Because Indonesian people is also asking, if I'm willing to give my kidney to patients, what about my
Your health?
condition? So, Ibu Teti already answered.
No medicine.
Yeah, no medicine,
Nih.
activities.
Ya, saya bekerja 30 jam satu minggu.
Yeah.
Dan saya juga punya penyakit thalassemia ya, yang tekanan yang blood unmuda. Selalu, tapi tidak apa-apa itu tidak. Ya, bukan tekanan darah. HB-nya selalu rendah. Cuma 5,4, 5,5 so. Tapi nggak apa-apa kan, sampai sekarang masih bisa.
Dari Oke, mungkin dari penonton. Is there any questions from the audience? And please raise your hands and address to whom the question will be addressed. Please. Yes.
How much is the cost for you a month for the medicine?
Oh, di sini ya.
Or you are from the Netherlands? But you know how much it costs a month?
Cost?
Yeah.
Kita bayar
For insurance.
versekering.
Yeah, but you know how much it costs a month or a year for the insurance of
Oh,
maybe
1
Niko
bulan ya
or
tinggal
Prof.
ya. 1 bulan aja udah dapat rekening 10.000 euro.
10,000
1 bulan
pounds.
ya. Tapi tidak kita bayar karena kita pakai versekering.
Yes, I understand.
Yeah.
And you know how it costs for the patient and for the family.
Yeah.
10,000 euro a month.
Yeah. It depends a little bit on the match. If you have a very good match, then you need less medicine. So actually, we love to have family-related programs, and so we have a bank, and you can say, okay, I love my partner, man or wife, very much, and I put my name on a list. And then you give DNA and all the characteristics. Then somebody at a completely different area also wants to have the kidney for the partner. And then we match, and then we do the operation at the same time, at the same hour.
Yeah.
Because otherwise, you have always the risk, and that happened in the past, that you said, okay, I give my kidney, and it will be to Groningen. And then the person in Groningen said, yeah, but I said I want, but now I do not. So you have to have at the same time anesthesia. So there's connection. And you don't know the name of each other. It's anonymous. So you cannot go to the person in Groningen who has given the kidney and say, you has not given me a good kidney. You cannot do that because you do not know the patient. And that is the national rule, but you can get more transplantation. My cousin got lung transplantation because she has cystic fibrosis. Her husband has also cystic fibrosis. She died because he died because he was not early enough in transplantation. But my cousin Kim Moulans, she was in time, and she asked me each time, Uncle Frans, can you give me the name of the person, because it happened at a car accident in the south of Germany. Can you give me the name, because I want to write a letter and to thank for the new lungs. I said, no, I cannot give you. I don't even know myself. Not even the chief of the surgical department knows the name of the person who has the car accident. But we give that all together, and we have a euro transfer.
Okay. It's just a follow-up question on that one. What is the incentive for the donator? Does it work like in the blood system that you know that some relative of yours it's in need of the blood, for instance, and you donate, and you expect that at some point that blood will go into this person? Does it work under the same regime, or does it work differently?
Yeah. And of course, it has the advantages that you might have accidentally a good match, but usually the match is suboptimal, and then you need a lot of drugs, and drugs can go up to 10, 15, 20,000 euros per month. And so these drugs then are less needed. We even have in excellent matches, the best matches, of course, father and daughter or whatever, or mother and son, whatsoever, or brothers or sisters. And then sometimes you have only 500 euros per month.
Okay.
Terima kasih untuk Bapak yang tadi habis transplantasi ginjal. Pengganti lithium yang sudah biasa diberikan itu dari resep dari dokter. Iya, ada ganti.
Ada gantinya, depaknya.
Nggak ada efek samping lainnya.
Sampai sekarang.
Kemudian untuk ibu, kan tadi ibu mengatakan HB-nya sangat rendah. Itu memang sebelum transplantasi sudah sebelum donor sudah tahu. Kemudian setelah itu ibu untuk mempertahankan kondisi ada exercise tertentu atau mungkin ada sesuatu yang harus dimakan? Tidak ada. Ibu tidak terganggu untuk kegiatan saya. Oke. Jantung nggak apa-apa?
Kan sebelum dioperasi semua diperiksa semua ya. Kalau ternyata setelah sampai meja operasi ternyata tidak cocok, bisa ditukar sistem keras seperti yang Bapak bilang tadi, sistem keras di sana.
Terima kasih. Any other question? Yes. I have two questions. The first one, your name is? My name is Randy. I'm from Amsterdam. I'm in PhD there in the field. The first question is who organized the arrangement, like who has the database? Is it government or it's a non-government organizations, or who handles that? Maybe the second question is,
you can answer.
in Niko, how do you think we can handle it? Because Indonesia is very broad country, so like Netherlands. From going in 2 months, so with the transportation, you can send a kidney just in 2 hours, and even helicopter is half an hour. And how do you address that? Do you think we can handle that in Indonesia? So that's it for me.
So the first question is it's a sub-governmental organization. So it's not really the government. Our university is not really the government, but it's totally financed by the taxes and by the government. So that is also with Euro transfer.
May I ask about another question about this? Yes. Because I know that my friend, she's relatively young, yes, but she's already got the questions that when you die,
yes,
are you willing to donate some of your organs? Do you have that kind of system incorporate in the registration?
Yeah, that is the battle that my cousin who has lung transplant. We want to have passive donation.
Okay.
But in the Holland, it's due to religious reasons and not a law. But in Belgium, it is a law. So either you write down that you permit, if you have a car accident, that your organs are going to other people, or you have not, there's the cardiologist, or you have not registered, you forgot to register, and since you forgot to register, we can then say, okay, you will be a donor. And that is in most European countries. So we suggested, if you have, for religious reasons, no willing to donate, in that case, you should write it down. If you have not written it down, you will always be a donor.
Okay.
And that is now what we like to have in Holland. And we think that we are not doing it right. I belong to the group who thinks if you have forgotten to write down that you don't want to be a donor, then you should be a donor.
Okay.
And then the second question is about the distance. I think heart transplant, lung transplant are being done in Utrecht also. You can easily fly in from Italy, from the north of Germany, from Spain. You can fly in 2 hours from Den Passer to Jogja, or from Jogja to Bandung, whatever. So I'm not worried about the Indonesian system. So many airports in Indonesia.
In Indonesia, I think that is why I titled this the potential solution, because why? Professor Moll said it available feasible in Indonesia, airports and everything. But the first, government should increase the health budget. The health budget at 5%, it should be there 5%, not 3%, not 2%, but 5%. Okay, that's fine. And as you can see, dealing with healthcare is two ministries actually: Ministry of Health and Ministry of Education. Like me, like Professor Azhari is Ministry of Education, and Ministry of Education we have University Hospital. So I think that could be the potential solution to build infrastructure. If health budget only 5%, for education we have a 20%. So I think that's why I have to encourage more. We can do it as long as we have a good team.
I think again the message is collaboration.
Yes.
Inter-departmental collaboration is always necessary in order to overcome some problems. Because I can really understand your concern, because from here to
I don't think the problem is about the number of money, not the budget itself. The problem is the management. Like our money is not. It's not because we don't have money, but we cannot organize it well. Like if you see, for example, the scholarship itself, we even have to go with the LPDP, which doesn't make sense. So I think it's not because of the money, it's because of the organization itself.
Yeah, that's why. Yeah, I agree with you.
Yeah, so I think the first thing is not about the increase the budget 5%, no, but how to make it better. I think.
Objectively speaking, that the current allocation for Indonesian expenditure is only 3%. That's quite low. Yes, that is true. And the second thing, that everything cannot be overcome by adding some money. Of course, that's also true. It's always need to have both sides equal. You have need to collaborate with other people and also have a resource to deal with that kind of problem. Okay.
First, I have two issues. The first one, I just want to respond to the last question regarding. Yeah, I think I will certainly agree with you that the problem is, of course, not just about the money. The money, of course, is a problem, but that is not the only problem. Again, coordination and also across departmental coordination will be really helpful, because when you mentioned that the education budget is 20% compared to the health budget, that is not because when we consider about education, not only for education itself, but also has other fields of or other departments, including health, education, and health. My second point is a question regarding to Dr. Niko's presentation of BPJS. I'm not fully aware of that because BPJS was introduced while I was here, so I didn't really get in touch with that. But I heard from my colleagues there in Indonesia that even when with BPJS, even more complicated than the previous programs. For instance, for the government employees, we used to have the ASKES. What is actually the difference between ASKES, BPJS, and ASKES? And then will BPJS also provide us with the coverage for kidney treatments, for instance? Thank you.
Yeah, that's very nice question. Well, actually, first, I'm not the expert of BPJS, but I'm following every discussion of BPJS. And yes, BPJS is transformation from the old insurance that we call ASKES, Jam Sostek, Jam Kesmas, and everything, into one big insurance program by the government, following the WHO. Yes, well, for kidney transplant, I should say, I have the answer about it is covered 250 juta, 250 million rupiah, and in the tariff, book of tariff, it is the biggest coverage. So that's why I also say that this is potential to be done in Indonesia because it is covered.
That's the maximum coverage.
Maximum cover. It is, yeah. This is also bigger than heart transplant and lung transplant. Yeah, it's the fact. It's really the fact. So kidney transplant is the highest tariff in coverage in CBG, BPJS.
Compared to the expenses that patients have to.
Yeah. I followed the discussion that patient transplanted in Bandung. The patient still had more about 10 million, 10 juta something. Yes, and also in Malang they had more 5 to 10. So yeah, I think the conclusion is that I can take just one. So kidney transplant is feasible because national coverage them, but we should build the management, like Fabi said, management. We should put on the units, because I learned here in the center, the unit is running, not in the general hospital like there is a patient. So we are waiting. No, we have to build it first. Don't have to be like big center, but small groups, dedicated, solid team, but ready for everything. And of course, they should be ready for promoting, telling everybody about it. And I think that is the good idea, management.
Advocating
Yes.
the stakeholders to
be
much more aware about these issues is also. Yeah.
Hello, my name is Hidayat.
Yes.
I'm from Rotterdam. I'm not from a medical background, so probably my questions are too easy to be answered by the speakers. First, my questions was referring to the videos from Dr. Niko.
Yeah.
It was said that she has successfully transplanted the kidney, but she cannot buy the medicine. All right. First, my question is there any generic medications already in Indonesia, specifically or in the world, or there's still medicines that's sold by the commercial medicines producers? And why that the transplanted kidney peoples, if you can say that, still need the medicine? Yeah, probably it's to recover their health conditions after the operations, but for how long? Is it for the whole of their life or just for certain times? And my second question is, it's related to the Indonesian regulations. I did a few research. I hope it doesn't change. That we are only allowed to transplant the kidney from living persons. So we are not allowed to transplant the kidney from the dead persons. So yeah, probably the regulations maker thought that it will prevent people to kill each other to get only their kidney, probably, I don't know. But from the medical perspective, is there any differentiations between transplanted
from living donors
or from the That's my question.
Yeah. Okay. Well, actually, I already explained to Mr. Roy tentang medications. Yeah, after transplantation, they will take for their whole life, so they will see medication 12. Kalau Pak Roy 12 pill. Yeah. And but like Professor Moll said that it depends on the match. If they are closely matched, it will of course reducing the pills. Yeah, that is the first idea. And patent and merit. Yes, well, actually, government try to make it as efficient as can be. So generic is the first thought. So, but if there is any, so patent will be the medication that we choose. Yeah, about living donor and post-mortem or cadaver, we call it that way. Two types of transplant, living donor and cadaver. That's the thing that I came up with this kidney transplant, because Indonesia is not yet ready for post-mortem or cadaveric organ. That's why I'm not good for lung transplant. I'm not good yet for maybe 20% of the grade. 20 years later, maybe I will try to encourage that, but not now.